Hi, everyone. Thank you so much for being here. This is the fourth lecture in the series, Health Insurance and Organizing. This lecture is entitled Universal Healthcare, What It Can and Can't Solve. Again, I want to remind you all, no matter what background you're coming from, faculty, friend, student, please sign in. That would be very helpful for us. And I'm excited to start our lecture today. So I'll give you all a second to use the QR code. And on Zoom, if you're having any troubles, please just tell us in the chat. Okay, I'll go ahead and move forward. So yes, as I mentioned, this is a lecture, Universal Healthcare, What It Can and Can't Solve. I want to thank everyone in the kind of title above. Everyone there had something to do with today's lecture. And we have three speakers for today. So one is Dr. Petruzzi. She'll be the one who leads us today. It'll be followed by Gabby Lee, our very own, an MS1 at Dell, and then I'll wrap things up at the end. Although, as I've told you all before, the first three lectures have been a lot of content. I recognize that. We have everything recorded, and in every advertisement email, we have the link there. If you have any issues, you can always reach out. But those covered a lot of content. Today, we're hoping to have this be as participatory as possible, which is, of course, why it's raining today. So that's why everyone is coming in through Zoom. But we really want y'all to participate as well, and we have people monitoring the chat. This is a reminder to please sign in. So if at Zoom you decided no, please yes. And then one other reminder is, this is even more important. I'm being super annoying about this, but I just want y'all to know that we want this series to be sustainable for a bunch of different schools. And so we're hoping feedback from any kind of background will help us improve this series. So this is the QR code for that. And then with that, we'll go ahead and start. I just want to remind everyone that our very first lecture, we kind of had a basic introduction to the U.S. health non-system, who the actors are, how much our system costs us, in terms of financial resources, and also our reduced health outcomes here. Our second lecture, we went over privatized healthcare and organized capital. So basically the idea of how privatizing our only public insurance program in the United States has affected both patient care and also physician practice. Last week's lecture, we covered basically the effects of COVID on health outcomes and why we were acutely affected the way we were because of how our non-system operates in the United States. We have the most number of COVID deaths. And so today we're going to go ahead and cover basically three main things. So you can expect, we have learning objectives that are more formalized in our feedback form that I hope you use the QR code for. But essentially, you should have three takeaways from today. One, we're going to start with differentiating how programs like the Affordable Care Act impacted access to healthcare and other kind of metrics, parameters, versus how a system like Medicare for All would end up impacting our system. Second, we're going to do a quick compare and contrast of two current universal healthcare systems. So like we talked about in our first lecture, universal healthcare does not mean one system. It means an outcome of having everyone have access to health insurance. But there are different ways they're set up, and naturally there are consequences and problems with every system. So we want to kind of, talk about that. And then finally, this is going to be the most participative portion of our lecture today, but we're going to define what coalition building is as a strategy, understand how that can be applied to something like advocacy for universal healthcare, and then we'll think about issues that we're each passionate about, identify actors that we think we could build coalitions with, and I'm going to call on a couple people to please present what you come up with, and so this is your warning now. And so with that, I'll go ahead and have Dr. Petruzzi start. And so just give us a second to pull up those slides. Oh, sorry. Oh, yes, the sign in is there. Thank you. And Dr. Petruzzi, if you'd like to introduce yourself, you can, yeah.
Well, first of all, thanks so much for having me here. I'm super excited. So my name is Liana Petruzzi. I have a PhD in social work, so that's the doctor part. I'm not a physician, but I am a licensed clinical social worker, and I've spent the past 10 years really focusing on healthcare access, healthcare disparities in both hospital and healthcare settings in a clinical sense, and then also doing research. So I'm hoping, and this is something I'm super passionate about, universal healthcare. So I'm just really excited to have the med school and you guys really taking charge of getting this information out to students and hopefully leading to some advocacy and all of that. So super excited to be here. So today we're going to talk first about the Affordable Care Act, kind of what is it, what did it do, what's been happening the past 10 years, and then talk about what are some of the gaps, what did it not solve, and then we'll talk about universal healthcare. We're specifically going to be talking about Medicare for all, since that's basically the most fleshed out version of universal healthcare in the United States. So we'll kind of dig into that policy and talk about just where we're at with it. Yeah, and then talking more about coalition building later. That sounds cool. So wait, this one? Okay. I'm gonna get it. Okay, cool. So just a little bit of background about myself. I know I already sort of said this, but I worked in several different hospital systems in several different states, and started my career more in research. And even within the field of research, I think access to research is super difficult in terms of how people are getting paid, who's getting recruited, things like that. And so even though I started there, when I went to social work and decided to get my my master's, I was still really interested in healthcare. And I came to the University of Texas to get my master's, and I worked at Breckenridge / Del Seton for 2 years before going back for my PhD. And what really kind of motivated me was the program that I'd been working for was a Medicaid waiver program. So essentially, when Texas didn't expand Medicaid, there were all of these block grants where the state could say, yes, you can serve the population that essentially would be getting Medicaid if we had expanded. And the work that we were doing, obviously I'm biased, but I thought was super phenomenal. We had an interdisciplinary team with social workers, community health workers, physicians, dietitians, and we were doing transitional care, helping people from the hospital navigate to primary care, navigate to specialty care. We did home visits. I was meeting people at Social Security to help them to get disability services. I mean, the work that we were doing was really impactful. And when that block grant ended, Ascension decided not to continue the program. And I think the leaders involved were actually pretty shocked. Like, I think they just assumed that Ascension Seton would do the right thing. I don't know what ever happened to that data. I never saw it. It was, I mean, the state owns that data, right? But to me, I thought it was like such a missed opportunity for us to really look at how important and impactful these kind of social care interventions are. And that was what really motivated me to come back and get my PhD, to do more intervention research, to really test the efficacy of social care interventions with social workers and community health workers. Because if you talk to physicians, if you talk to nurses, if you talk to people in the healthcare system, they're like, yeah, social care is essential, right? Like, we know that there are these social determinants of health. We know that people want to be healthy. And the reasons that they're not is not because they are non-compliant. It's because they can't afford their medication. It's because they don't know where they're supposed to be going to get certain services, or they don't know how to fill out certain forms, or all these different barriers. So that's just a little bit of background about why I do the work I do, and why I'm also super passionate about universal healthcare, because I feel like all of the research that I'm doing right now a lot of it could be solved if we just had universal healthcare, because so much of it is helping people first figure out what are they eligible for, and then helping them navigate through that. And then, their eligibility changed because they got a job, or because they retired, or because they got divorced. And now we have to kind of do the whole process over again, right? But if we had universal healthcare, I think a lot of that wouldn't necessarily be the case. And then we could actually focus on the quality of care and addressing, a lot of the other issues that our healthcare system has. So I already kind of said the things I'm going to be talking about. But just to kind of start with, what is the Affordable Care Act? So prior to the ACA, the vast majority of adults between 18 and 65 enrolled in employer-based insurance. So this meant that people who were working part-time or self-employed often went without insurance. So the ACA created a public marketplace to make it so that people could purchase private insurance. And then they provided federal subsidies for people between 100% and 400% federal poverty limit. And then it also included a lot of patient protections. So for people with chronic conditions and young adults, people with chronic conditions, basically previously health insurance company would say, ooh, it seems like you're pretty sick. We're actually not going to cover you. And then young adults, as soon as you kind of left home and went to college, well, you don't have a job, but you're outside of the home. And so all of a sudden you'd be in this gap. So it extended coverage to the age of 25. And, it attempted to restructure healthcare delivery. So, it incentivized value-based care. It established primary care homes, and care coordination and integrated care models. But what it did not do was it didn't change the way that we pay for healthcare. It didn't change the cost of healthcare. And, unfortunately, we don't even have reimbursement for a lot of these care coordination and integrated care models that are being incentivized. So, if you don't have grant funds, or if you don't have a block grant, or if you don't have a state that is doing something very specifically to invest in these programs, you probably don't have access to them, or they're going to be time limited. So some of the successes. So something else that the ACA did was that it incorporated the Mental Health Parity and Addiction Equity Act. So this meant that health insurance plans had to provide the same level of benefits and coverage for mental health and substance use services as they did for chronic illnesses. So previous to that, that was not the case. And it also led to a drastic decrease in the national uninsurance rate. So these numbers are kind of old, but we're probably still around 7-8% right now anyways. And we really increased access for young adults, not surprisingly. And then for people with mental health and substance use needs, they were able to get more access to care. So that's the good news. Some of the limitations that have happened. So as I was saying, it maintains the fee-for-service reimbursement structure. So it's not regulating healthcare costs. It's not consolidating insurance plans. So there's nothing more simplistic about it. And you could argue that it's actually more complicated because every state has a different set of marketplace plans, and that can even vary by county or by region of a state. So, if you moved from Dallas to Houston, your plan might not be there anymore. It gave federal subsidies to people to access private health insurance, but it also has stipulations. So if you make less than 100% the federal poverty limit, but your state didn't expand Medicaid, you can't really access the marketplace. And then, if you're above 400% the federal poverty limit, there are several people, or there's, a large chunk of people who maybe they could afford the premium, but they still can't afford, the cost of care. For them, it's actually cheaper to just remain uninsured and have their healthcare dollars spent on accessing the services they need, as opposed to paying astronomically high premiums or out-of-pocket costs to then access the care that they would be, without that insurance. I think we all know that Medicaid expansion was struck down in 2014. So essentially what that meant was that each state could decide whether or not they wanted to expand Medicaid and what that expansion would look like, who would it include, what would the federal poverty limit be. We still have almost 30 million Americans who are uninsured. And 7 in 10 Americans maintain a negative view of the healthcare system. And then, of course, when we're compared to other high-income countries, we rank very low towards the bottom on access, equity, and health outcomes. So I think this map is really helpful. Oh, can you maybe? Oh, no, you could. Sorry. I'm going to go back for a sec. I think this map is really helpful in terms of showing us just where we're at right now in terms of Medicaid expansion. So we have 39 states that have expanded Medicaid and 10 that still have not, including Texas, and 2 that are in the process of implementing Medicaid expansion. So that'd be South Dakota and North Carolina. And, if this is something that's interesting to you, the Kaiser Family Foundation has a wealth of information that they keep very up to date on this. So a lot of the information that I'm going to be sharing in the next slides are from the Kaiser Family Foundation. So this graph or graphic helps us understand what I meant by the Medicaid gap, right? So I was talking about people who have less than 100% federal poverty limit who wouldn't be eligible for marketplace, but who might be, and in the case of Texas, are over the federal poverty limit for Medicaid. So you can see over on the side that there's kind of like a 0% to 41%. And then it's limited to specific low-income groups. So in Texas, you have to be over the age of 65, disabled, or a child, like a pregnant person or a child. So very specific groups. If you are a childless adult, you're not eligible, assuming you're not disabled and you're under 65. So this really just kind of shows that coverage gap. And I think it also helps us understand like what are those eligibility criteria that we have to consider. And then this slide or this graph shows like where are people that are uninsured. So most of them are in Texas. We count for almost 50%, 41%. And then Florida is another 20%. So between those two states, that's the majority of them. Then we also have Georgia, Alabama, and Tennessee. And then the other states are kind of combined there. But this is just like a reason why, as healthcare providers and advocates in the state of Texas, we should constantly be saying we need to expand Medicaid. And I know the legislature right now is considering expanding coverage for pregnant individuals from, I can't remember if it's 3 or 6 months currently, but they're trying to get to a year of coverage. So yes, that's great. But again, it's for a very small segment of the population. And 41% federal poverty limit is really not a lot of money. Like people are being expected to live in abject poverty. And so, this kind of talks about like comparing state by state, what percentage of people meet the eligibility criteria, and then compares parents and childless adults. So Wisconsin, I guess, has some special block grant, as I was mentioning before, that does cover childless adults, but the rest of them do not. So, okay. And then the other thing to kind of know that even with Medicaid expansion, we do still have racial and ethnic disparities. This isn't necessarily surprising. Plenty of countries that have universal healthcare still have racial and ethnic disparities. So I think it's important for us to understand that while expanding access is essential, it doesn't automatically improve quality of care. It doesn't, eliminate racism. It doesn't do a lot of those things. Those are kind of baked into the system outside of just, do you have health insurance or not, and can you afford it? But, most of the studies that have looked at racial and ethnic disparities have found that they've done a pretty good job in improving insurance coverage and access to care, but less in terms of health outcomes and economic measures. And then I did just add this slide because this literally just happened, but this is a recent federal court case, happened in Texas, that essentially allows private insurance companies to decide whether or not they're going to cover a range of preventative services that have been approved since 2010. So anything that was recommended before 2010 is fine, but it's for newer recommendations that have been made that private health insurance might decide they're not going to cover it at all. Or they might say, well, we're going to cover it, but you have to engage in some of the cost sharing. So you're going to have to pay something out of pocket. And so, some of the specific things that were impacted were PrEP, colorectal screenings before the age of 50, lung cancer screening for people who are at an elevated risk. And again, Kaiser Family Foundation has some great information on this, but this was like a table that they made that kind of identified all of the things that have been suggested, these evidence-based preventative measures that have been suggested since 2010 that may either not be covered by private insurance anymore, or it might be covered, but at the cost of the individual. And just some other ongoing challenges in terms of what the ACA, hasn't really addressed. So obviously we can see that across racial and ethnic groups, there's a decrease in the number of people who are uninsured, but there's still a pretty big disparity in terms of who are those people, who are those individuals that are uninsured. So Hispanic individuals, consistently both at the federal and state level, have the highest rates of uninsurance. And obviously we could have a whole other lecture on the intersection of healthcare legislation and immigration legislation. But that is a huge disparity that exists. And then Black and African American individuals are the second most likely to be uninsured. I will say that even though this graph says that Asian Americans have a pretty comparable uninsurance rate to white Americans, the Asian population is super heterogeneous. So depending on the group that you look at, they could actually have really high uninsurance rates. It just kind of depends on where they're from, what their ethnic identity is, when did they move to the country, things like that. So I do want to give that caveat. Like if you went to Houston, for example, there are plenty of individuals that do not have access to health insurance that are Asian. So that data is just, it is what it is. Affordability is another thing that the ACA didn't really address. So because they didn't include in the legislation anything that changes the cost of health insurance or the way that it's reimbursed, costs are incredibly high. If you lose your job or you change employers, that means you have to figure out a new insurance. Because of Medicaid having a pretty low kind of income threshold, people can lose Medicaid if they take a new job or if they Thank you. Just gonna see if I can leave that there. So I think, it's important for us to think about why are people uninsured? And these were some of the top reasons from people in 2017. But again, affordability is by and large, the leading cause of people not being insured. So obviously the ACA did not solve that. And then finally, the other piece related to affordability is this idea of being underinsured. So, underinsurance is basically the out-of-pocket expenditures that you have if they're greater than 5% of your household income, or if you're not accessing medical care or prescriptions because of the cost, then you would be in this kind of underinsured category. Do you technically have insurance? Yes. Can you afford to use it? No. So it's not really serving you in the same way. And this bottom part is talking about how the rate of uninsurance. So you can see, yes, it did drop. But what really increased was the orange category. So insured all year, but underinsured. So we can see that as uninsurance decreased, underinsurance increased. Okay, so the big question is, can universal healthcare solve these problems? So as I said, for the purpose of today, we're going to talk about Medicare for all. But as Yosha actually mentioned in the first lecture, I think universal healthcare isn't about one policy or one system, right? It's about interconnection of different healthcare policies and services, and we'll also talk about that a little bit more towards the end. But some of the details in terms of Medicare for all. So first and foremost, it creates a single payer healthcare system. So this means that everyone gets access to Medicare, hence Medicare for all. It removes cost sharing system, which actually does exist currently. So it wouldn't just change access, it would change how the program is being implemented. So it would remove premiums, it would remove co-pays, and it would remove co-insurance. And at the second lecture, there was a lot of talk about, people enroll in Medicare Advantage plans because it costs them less money in the moment, right? So this is a real impact on how people use their Medicare. It pays for healthcare coverage through federal taxes. So it's totally removed from the employer-based system that currently exists. You're automatically enrolled at birth, so there's no paperwork to fill out. And then there's comprehensive benefits that kind of go beyond the ACA's 10 essential benefits. Things that it would also add, it would add dental, it would add hearing, it would add vision, it would add home and community-based long-term services, also known as Medigap. There was a good conversation about Medigap during that second lecture. So I'm not going to go into it now, but those services people often get through that. And then it would add transportation for individuals with disabilities and low-income individuals. So it would really expand, what's currently provided. So in terms of costs, generally speaking, there are lower administrative costs due to lifetime enrollment. Having one insurance provider, you don't need a million different insurance providers at the regional level, at the state level, at the federal level. You're not going to be asking for permission to get health services, you would just be getting them. It also lowers reimbursement rates and pharmaceutical costs because the government would actually be able to bargain with providers, hospitals, and pharmaceutical companies. So it was a big win, right? That the government said, we can now negotiate pharmaceutical costs for Medicare. Like, that's great, but it's, again, only impacting a very small segment of the American population. There would definitely be an increase in federal spending. over, the year and 10 years it was implemented, but it would save state and local governments billions of dollars and upwards of trillions of dollars. And private healthcare spending by employers would drastically decrease. So from a economic perspective, it basically means employers don't have to worry about that anymore. And I think there's a huge administrative burden on companies having to try to figure that out, right? As plans are constantly changing. And I'm even thinking about here at UT, like when they made changes to what graduate student healthcare plans were available, it was a headache. There was several spreadsheets. Even knowing all this, I was like, I'm still sort of confused. So, I think that it would save a lot of administrative burden, like even outside of employers specifically. In terms of some limitations, so there's a divide within the Democratic Party, and I made these slides when, a few years ago when this was a little bit more being discussed. But I do think it's important to know that within the Democratic Party, which is the party that discusses universal health care, this idea of should we tweak the ACA, should we make incremental changes, right? That's the platform that Biden, ran on, or should we have a single payer healthcare system? So, there's a divide there that I think we have to acknowledge, even as people who, may be within that party or are talking to other folks who, in theory, want health equity or want to, improve health outcomes. It's really unclear, like what would happen in terms of undocumented immigrants and how this would interact with immigration legislation. And then, there was one analysis that basically very specific to the Medicare for All proposal that Bernie Sanders put together was saying like, oh, the numbers don't quite add up. So I just put that in there to be totally transparent. I don't think that means that it wouldn't save us money. I definitely do. But I think that there hasn't been the adequate investment in trying to figure out how do we make this work and what are the actual costs, because people are so focused on like either building it up or tearing it down as opposed to like, how can we just make this work? Okay, so major takeaways. So number one, health insurance, not related to employment. Whether you're employed or not, you can have health insurance. You don't have to worry about losing your health insurance if you're going to leave a toxic work environment. You don't have to worry about employment within a family system in terms of, covering children and all of those things. Your costs are income-based because they'd be based on your taxes, and they don't prevent you from receiving services, and they don't lead to medical debt. Substantially reduced administrative costs. We talked about that a lot, but for several reasons. The prior approval piece was talked about a lot during the second lecture, so I think that that's important to note, right, when we're thinking about access to care. It decreases the overall healthcare spending due to standard reimbursement rates. So, private insurance reimburses at the highest, Medicaid reimburses at the lowest. That really impacts who offers services, and where those services are provided. So if everyone was reimbursing at the same level, it would actually increase access to quality of care. And then lastly, the purpose of health insurance kind of shifts. We're not talking about generating profits. We're not talking about what things can we cut so we can make more money. We're talking about how can we provide quality care to the people that are supposed to be covered. So those are all my slides. Happy to answer any questions. Yeah.
Thank you so much, Dr. Petruzzi. And what we can do also is y'all can sit on it. And if there are any questions, we're having a participative environment later. So you can also keep it in the chat. But next, what we'll go ahead and do is we'll have our very own Gabby Lee talk to you about two universal healthcare systems. So like we mentioned, and are kind of trying to drill home, the idea is that universal healthcare is an outcome, not any one system. And so what we want to do is explore two countries that have implemented such systems that have achieved that metric, and kind of discuss what are the continued limitations, what are the continued challenges that those systems face, keeping in context that every country is different in terms of their demographics, in terms of their population's chronic health disease burden, things like that. Okay, yeah, there we go.
Thank you. Thank you so much to Dr. Petruzzi. I think it kind of leads very well into kind of what I'm going to talk about. But I think a lot of the questions that I had when I started learning about single payer system is, okay, so we don't have it. but a lot of other countries do, and what does that sort of look like? And the bottom line is it looks super different no matter where you go. So these are just two examples, and it's going to be a kind of an exercise in comparing it to the US and kind of seeing maybe what ideas we can take from other countries or what components that we think might fit into a potential US system. Yeah, so we'll just get into it. So the first country we're going to talk about is the UK. And of course, we can't compare these countries to the US in a vacuum. So I put the US stats up there as well. The US has the highest GDP in the world and the third largest population and is, of course, very ethnically diverse. So those are considerations that we must have when we talk about healthcare systems. The UK, in comparison, has a lower population, a smaller GDP, but of course is a very developed country with a very high level of wealth. And then the ethnic group breakdown, about 82% white, and then about 18% Black, Asian, mixed, or other ethnic group. So just a little snapshot into what the UK looks like. Okay, so for the UK, their health system is called the National Health System or Health Service, and it's basically where the government is both the insurer and the provider. So there's our government, and in the government we have the insurers, we have the providers or the doctors and hospitals. So everything is run by the UK. They own the hospitals, the doctors are basically government employees, and they're the ones that are providing insurance to all of the citizens of the country. So there are patients, and they're funding this system through general taxation. So, I mean, we probably all kind of figured out that a lot of this is going to be funded through taxes, and that's kind of what the UK is doing here. Also, you can have voluntary supplemental private insurance. So there is a significant private insurance system in the UK. And about 10.5% of citizens in the UK back in 2015 did have private insurance. And it's also important to note, even though the UK is, running everything, it is a very large country. So there are a lot of like smaller clinical commissioning groups where basically we outsource the work of like regulating and running these hospitals. So the government is just sort of overseeing it, it's setting the boundaries, and then these smaller groups are sort of doing the work at the regional level. Okay, so some of the pros and cons. So first, of course, coverage is universal for all residents, regardless of income. Even if you're not a citizen, if you're a longstanding resident, there are some ways for you to get universal coverage as well. And this universal coverage is largely free at the point of use. So that cost sharing that we kind of talked about before, you don't really have that. It's very minimal. And especially for things like prescription drugs, it's a fixed price at about $11, no matter what drug you're getting, how often you're getting it, or the quantity. So a cancer drug will be as much as, say, an antibiotic, up to $11. And of course, these services will include hospital, physician, and also mental health care. Some of the cons of the system, something that some people are very aware of, they have very notoriously long wait times in the UK. A lot of this stems from staffing shortfalls and a lack of funding. And of course, that's not something that we see all the time in the US, but it's not a problem that is unheard of here. Something else that we often tend to see is that whenever these patients are facing very long wait times, they'll go to that supplemental insurance, that 10% of people will pay out of their pocket to do that. Is this working okay? If you just only hold it by Sorry, I've never used one of these before. So a lot of patients will turn to that private insurance sector and go for that and get more rapid care, more convenient care, but that's typically only for elective hospital procedures. It doesn't include primary care, it doesn't include maternity services or emergency care, and it's quite expensive. So if you can afford to get it, then you'll get it, but if you can't, then you're kind of stuck with those long wait times. Additionally, the way the UK works is everyone is required to register with the general practitioner, and that general practitioner is kind of the gatekeeper of all of your medical services. So if you want to see a specialist, you have to see your GP first. But of course, if you have to wait a long time to see them, it could increase that time to get your specialist visit. And then kind of like Dr. Petruzzi talked about, just because there's universal health care in the UK does not mean that there aren't these health disparities that we're seeing very similar to the US. So specifically people that are Black, Bangladeshi, Pakistani, these people are facing structural racism and discrimination in their healthcare system despite having universal health care. So those problems certainly do not go away by any means. All right, and then now we're going to go to a different part of the world and we're going to talk about Taiwan. So Taiwan is a much smaller country in Asia, and it is very much ethnically homogenous. So about 95% of people are of Han Chinese descent, and about 5% are either indigenous or immigrants. And Taiwan, of course, has a much smaller population and a lower GDP, but their healthcare system has been heralded in many ways for its success and its relatively recent development. So how does Taiwan's national health insurance work? So instead of having the government be both the insurer and provider like we have in the UK, the government is just going to be the insurer. So they're going to provide the insurance and set the rules and price negotiation with providers, but they're not actually, owning the hospitals, they're not hiring the doctors. So patients and employers are going to be paying a payroll-based premium. So these are monthly payments based off of how much you make, and you also have a contribution ratio. So if you're in a job of higher socioeconomic status, you would be paying a higher proportion of your payroll every month, and your employer will also share in that cost. So a little bit different than general taxation, but it is mandatory, so everyone must pay these premiums. And then they'll take their dollars and they'll go to private providers, doctors and hospitals. And there is cost sharing in this case. So it's not free at the point of use. There are co-payments and co-insurance for outpatient services, as well as if you go to the hospital. All right, so some of the pros of the Taiwan service. So like I said, it's a relatively recent implementation. It was created just in 1995. So before 95, there were about 10 different public health insurance schemes for different groups. So if you were a government employee, you'd have one sort of health insurance. If you were a farmer, you'd have something else. And if you were a civil servant, you'd have a totally different health insurance. But then in 1995, when they made the NHI, all of these people are brought under one roof and under the same health insurance system. And we've seen a really high public satisfaction rate of greater than 90% in Taiwan. We've kind of talked about in previous lectures, the US satisfaction rate is not 90%. So that's something that's very important for citizens, and it is something that people talk about as sort of a keeper of peace, something they can rely on. It's not something they have to stress about in their daily life, having health insurance. And because providers are private, they are incentivized to see, as many patients and a diverse array of patients as they can. So we do see very short wait times, and also there's no gatekeeping of specialist services like we kind of saw in the UK. So you can go to a specialist, whoever you want. You can go to any sort of general practitioner that you want as well. And there's also safety nets implemented by the government. So we have generous premium subsidies for low-income households, for civil servants. So there is that already embedded safety net for those of lower income. However, some of the cons just kind of stem from the way that the healthcare system is formed in general. So there is a culture of healthcare overuse. So you can imagine if everyone has the same amount of health insurance, they'll see the doctor for as much as they want if they want to. And Taiwan specifically does have a culture of going to the doctor for minor ailments or for minor injuries and things like that. And so even though we have very short wait times, this can often lead to very low quality of those visits. So you often see a doctor for maybe 5 minutes, ask a question or two, maybe leave and not have all your questions answered and have to schedule another appointment or go see another doctor. So it sort of compounds this issue of these short wait times. And you also can't really deal with more complex medical problems that may need more time and energy to sort of work through with your doctor. In addition, because you don't have that gatekeeping of your GP, sometimes specialist services are used when they may not be necessary. So that's additionally a little bit more of healthcare overuse and some more healthcare waste there. And then finally, similar to the UK in that there are funding issues, Taiwan does have some difficulty raising their premium rates. It is a very politically charged topic in most countries, healthcare is. So whenever rates need to be raised to sort of pay for the payments of healthcare, there can be difficulty there. And of course, that would definitely be a problem in the US as well. All right, so just a quick comparison between the UK, the US, and Taiwan. So we saw the US is arguably the wealthiest country in the world's GDP, but we spend a disproportionate amount on healthcare. So just to kind of take a look at that. So the US is spending more than double per capita on healthcare, and then out-of-pocket health spending is also more than double compared to the UK. And then also the price on pharmaceuticals. So as a percentage of the GDP, the US is spending 16% of our GDP on healthcare, whereas the UK is around 10%, and Taiwan is even less at 6.4%. So a very big difference in how many dollars are going towards healthcare in general. And then just to reiterate, those dollars are not necessarily leading to healthier people. So in the US, the life expectancy is lower than the UK and Taiwan, and the prevalence of chronic conditions such as obesity and diabetes is much higher than that of the UK. And it's basically double for patients with more than one chronic condition. So I think there's a lot of lessons to be learned from other countries. These are just two. There's innumerable number of systems. But I think it's important to know that it's a really diverse picture of what universal healthcare looks like, and a lot of ways that bits and pieces can be implemented either incrementally or in more wide-spanning reform for the US. So just food for thought.
Okay, so another round of applause for Gabby. That was great. Okay, so yes, we've gone ahead and talked about how the Affordable Care Act is able to impact access to care, how that's different from how Medicare for All, which is the forefront of kind of any picture that we have for what universal health care could look like in the United States, and how that would impact access to care. We then went on with figuring out how in the UK and in Taiwan, two different systems that have achieved universal health care, how they are structured. So what we're going to go ahead and do to move on next is, so this is my favorite graphic that I have made, but just to kind of remember that what the ACA tried to do was, can I put it here? Yes, is make these bubbles bigger. So either it was through trying and ultimately failing because of how our legal system works to expand Medicaid. There were different types of moves that were made to try and increase this private health insurance bubble basically the most. And kind of what we talked about is that with every step incremental reform that was tried to have been made through the ACA, bit by bit, we're seeing how you have to fight for those crumbs. So first it was Medicaid expansion. Right now it's the preventative services stipulation. And we're playing this game of tag, of trying to keep what we have. And I just want to offer that, part of what Dr. Weisbart's point was in our second lecture was the idea of playing defense, fighting for the only public health insurance program that we have right now. Maybe that's kind of more of a strategic priority. So keeping the Medicare that we have, but just remembering that all of these battles are happening at the same time. At the same time that we're trying to keep Medicare is the same time that we're trying to have our preventative services continue to be funded. At the same time, we're trying to get Texas folks on Medicaid. Like all these battles are happening at once, and we each fit a different point in the social fabric of trying to keep everyone else healthy. So, I'm going backwards. Some of what we covered were the idea that there are still issues in systems with universal health care, so there are wait times. That number is about 26 to 30 days to see a primary care appointment or a specialist in the US. The highest is for OB-GYN, and I think it's about like 30, maybe it's like 35 days, versus around 50 days in the UK, as Gabby mentioned. Something that I have been doing the other lectures is trying to inundate y'all with information, and I'm realizing that maybe we can be a little bit more participative right now, and I'll just point y'all to some resources that I think would help if you're interested in this topic. So if you will look up the Osborne austerity measures that were done in the UK, that's something that I think would be useful reading for after this lecture. It's basically the idea of how conservative governments in the UK have tried to take away funding from the NHS. And I think it helps paint that picture of what wait times look like, because it is true that there are wait times in the UK, and it is also true that there is a lot of health inequity in the United States. And, how can you really compare apples, bananas, oranges, It's a little hard to understand, our system, is it better or worse than that? Really, I think it's best to compare a system against how it used to operate, how it operates now, how it will operate in the future. And so that's how you can kind of get a picture of how the NHS operated before those austerity measures were implemented, as they were being implemented, and now what it looks like now. Just some statistics that I'll offer include the fact that research from the National Institute for Health and Care Research, published in 2015, identified that austerity, or the idea of taking away funding from these social welfare programs in the UK, is identified as one of the factors responsible for a rise in suicide attempts and suicide deaths since 2008 in the UK. It is also likely to have resulted in 30,000 deaths in England and Wales. And so just to continue to remember that there are flaws in other systems, but it's best to understand those flaws in the context of their own system, their own population. Yes, so that was the point I wanted to get across. I'm really loving QR codes recently, and so I think that if you would like to read this as well, it's a really great comparison for other health systems to the United States and people that it would be easiest to compare to. Because I did just make the point that it's hard to compare, but these are the best measures that we have. And as was already alluded to, we are 11, 11, 11, 11, the last ranked in every single parameter except for the care process. When you look into this article and you think about, oh, why are we rated the best in care process? It is because at primary care visits, we do the most preventative care. So what that means is if you're able to wiggle your way into insurance, or maybe not even being insured, but wiggle your way into a primary care appointment, then your doctor will counsel you on tobacco cessation counseling. For if any of you know what it's like to be in the clinic, whether you're a medical student or you're providing other health services, you're a physician, you're like in social work or nursing, you recognize that talking about cessation or talking about tobacco cessation is a billing code that we don't want to miss out on. And so you do the cessation counseling of, oh, if you're ever interested in not smoking, let me know. Now, I don't know about you, but I don't want to rate our whole health system as based on whether or not a primary care provider says to you at one visit that you're maybe able to wiggle your way into, hey, do you want to quit smoking? But that's what this too depicts, is that we do that. I mean, at least we do that, but also in this article, I just kind of have it here, but we don't have to go into all of it. It gives a really good job of discussing what are the things that we need outside health insurance to try and get better health outcomes, because it's not just about insurance. So just a few things include what other countries do better for us besides just universal coverage and removing cost barriers, include investing in primary care systems and ensuring that there's equitable access across all communities to access that primary care. They reduce the administrative burdens on patients and clinicians that cost time and effort and take away from patient care. And they also invest in social services that increase equitable access to everything else around healthcare, whether that's nutrition, childcare, community safety, housing, transportation, things like that. Those are issues that universal healthcare will not solve. Oh no. Okay, I'm gonna escape and refresh. Nice, okay. Great. Last article, this is just another QR code for an New England Journal of Medicine article from last to first. Could the US healthcare system become the best in the world? This is a little bit of like a catchy title, but basically it covers some of the things that would help improve our system. And while one of them, again, includes increasing access to health insurance, the other points that are sprinkled in here include kind of buttressing our primary care system, so ensuring people have access to primary care and that that primary care is of quality, and again, reducing other types of administrative burdens, which the article gets into in specifics. But this is just to say that today, I'm not going to talk at you about them, but you can read about them on your own. And in the email that will go out to everyone, because you all signed in, so now I have your email, I will send this article as well. So this is my favorite part. We have about 10 minutes left, so I'm just going to spend around like maximum 5 minutes talking about what this means to me. Then we're going to have people break out. I'm envisioning maybe three, 4 here to just have a very quick 2-3 minute conversation for the prompt, and then we will share. If Zoom people could please chat, that would be so helpful. And then with that, we'll end. So what is coalition building? Through this lecture series, part of what we've been trying to talk about includes what is, number one, base building. So how do you build a base of people within your community where you all share a common hurt, a common goal, a common solution that you see together, and how do you have solidarity among your own group, your own community? Right now, we're moving on to how do you get bases to act together as a coalition in solidarity, again, for a common goal among you all, right? So there's, different bases, and how can we combine them all together to achieve a win? And this is following the theme or the framework that things are achieved together in numbers. So vertical power can be confronted by horizontal power, but you can only do that when you start coalition building. So the idea for universal healthcare, what it can and can't solve, this lecture, is in part about the idea of where are groups of people that are experiencing pain by lack of access to insurance? What are ways that universal healthcare would help those people? And then how do you get that person in your bucket? How do you get them in your cohort, in your favor? Yeah. And so I have 3 case examples. One is the idea of access to abortions. So these are all just kind of theoretical ideas here. I haven't put up a bunch of like evidence, but we're just going to kind of think about it in abstract. The idea that right now, before Roe v. Wade, before any of the changes happen to how we access abortion, even right now, the reality is that in a system that doesn't guarantee universal health care and instead makes you pay for it, abortion is a private commodity on the market that some people are able to buy and some people are not able to. And in fact, right now, some people are criminalized for trying to buy it, but that's what the criminalization part is about trying to buy it. And if, you know, for people who believe that abortion is a human right, there is an idea that a universal healthcare system is really congruent with that need. It's the idea that we're going to offer you a system that ensures everyone gets access. Everyone is on. It's not a market-based thing. It's something that is accessible to all people. So from there, you can think, okay, who are people in my community that I know who are part of repro justice orgs or really care about this issue, really are involved in this issue? What I could do as someone who's really invested in single-payer healthcare is to make community with that person and try and work together towards a common goal that benefits both of us. In contrast to that, and not direct contrast, but just a little bit, the idea of how structural racism impacts so many elements of life for people in the United States, I recognize that universal healthcare is not going to solve all that. I think it's really important to recognize that and state it out loud, because part of the history of advocacy for single payer, at least in very recent years, has been struggling to have people of color, physicians of color, students of color, health workers of color to be represented in that movement. And so it's really important to be intentional about coalition building. You can't just expect because someone may benefit partially from what your policy is that they're on board. Coalition building is a lot about having community with others. And so one example we can think of is even in the article that I mentioned, the Mirror 2021, a lot of, or one of the sections talks about how access to mental health care in other countries has been pivotal for reducing maternal mortality rates. That's not about access to insurance. That's not even about social welfare services or a program necessarily about maternal mortality. It's really just about recognizing that universal programs and universal access to something like mental health is important basically for maternal mortality. And so in that realm, we can think about how building coalitions with SNMA, the students of the National Medical Association, or other kind of organizations that have, you know, historically helped like people of color, students of color, patients of color to, you know, experience benefits. How can we build coalitions with those people? So anyways, those are kind of 2 examples of one where it's really easy to fit and one where you need to think really intentionally about how your program can help in some ways, but doesn't help everything. And what are ways in which that community can help you get your goal? How can you show up for that community as well? So that being said, what we'll do is we have, for the next 2 to 3 minutes, if you can in your little pod or if over Zoom, identify an issue area important to you. So whether that's getting people universal health care, whether that's access to abortion, structural racism, housing, transportation, whatever it is, identify an issue area that you feel passionate about, that you know you would go out of your way to do it. You're not getting paid to do it. It's taking up your time, it's taking up your resources, but you know that you're the person who would get involved with that. Then I want you to find 2 groups issues that interact with your given issue. Maybe it can be as easy as the reproductive justice and single payer, or maybe it's a little nuanced like single payer and structural racism. And how would you build solidarity with these kinds of communities. Remembering that these are not abstract communities, there are people in your cohort that maybe are affected by these issues. Yeah, so we'll go ahead and do that for the next 2 to 3 minutes. We've got about 30 seconds-ish left to wrap up your thoughts. Okay. Thank y'all so much for participating in that. So we're gonna have the Zoom folks chat in and I'll share if they share anything at the end. But since we have only 3 groups, I would love to hear from everyone. And I'm gonna see actually if this mic works. And so if you would just share with us, what is the issue area that you picked? What were the groups that you picked to build solidarity with? And then any reflection you have on your conversation.
Our issue was breast cancer, primarily with communities in East Austin. So we targeted the Latino Medical Student Association and the SNMA, thank you for the idea, and then their undergraduate counterparts to help provide the person force to actually push it forward. Logistics, we didn't really get into, but that's where our coalition starts. It's construction.
That is awesome. Thank y'all. And some applause for the group. And then next we'll hear from our next group.
Hello. We talked a little bit about public transportation systems and investment in infrastructure for building public transportation. And we talked about how that intersects with things like housing policy and zoning laws and gentrification and the ways that, that people get pushed out and forced to have more car dependence in their lives, which is bad. We also talked about climate change. It's also intersects with climate policy and things like that.
Nice, that's awesome.
Classroom.
We sort of talked about the connection between like minority groups having distrust in healthcare, which is partially driven by high cost of higher education, meaning that less minority people are able to become healthcare workers. And so I guess the coalition would be between like minority healthcare workers who want, you know, more representation, and also like current students or people who are looking to become students at higher education who want, you know, lower higher education costs.
Yes, awesome. Class for the group. That is great. This is exactly the point of the reflection, and I hope that, you know, kind of the takeaways that we can have from today include: one, what incremental reform is able to do for our non-system versus what an overhaul would do. What two systems with universal health care, what they're structured like. And then finally, with this activity, the idea of staying in your lane versus having that macro view, remembering that our issue areas affect different types of communities. And in order to kind of have that horizontal power to leverage against, you know, vertical interests, how you can build solidarity with people that you might not have considered when you first started with your issue area. So with that, thank you so much for being here. Please, 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 no matter where you are coming from, if you can, even if you gave this lecture, you can come and use this QR code to provide feedback. There are literally only 3 questions, and it's not literally, technically there are 6 questions, but it's about 3, it's a before and after, so it should be pretty easy. But yeah, thank you so much for being here, and next time, our last lecture ever, woo! Well, not ever, but our last lecture for this series will be next week on Thursday, not Friday. And we will have Dr. Rachel Madley. She is a PhD in health policy, and she is the health policy advisor to Representative Jayapal. She'll be featured for the first 30 minutes, and then we'll have another participatory activity. There will be fruits and snacks, and then we'll end. So thank you for being here. If you have any questions, you can come up front.